If your memory feels less sharp, could hidden oxygen crashes during REM sleep be chipping away at your brain?
Welcome to Dr. Mercola's Cellular Wisdom. Stay informed with quick, easy-to-listen summaries of our latest articles, perfect for when you're on the go. No reading required. Subscribe for free at mercola.com for the latest health insights.
Hello, and welcome to Dr. Mercola's Cellular Wisdom. I'm Ethan Foster, joined by Alara Sky. Today you'll see how sleep apnea in REM damages brain vessels, thins memory regions, and raises dementia risk, often before you notice problems.
Sleep apnea is repeated pauses or reduced breathing during sleep, often without your awareness. Events can last seconds to over a minute and strike dozens or hundreds a night. The most common form, obstructive sleep apnea, happens when tissues in the back of your throat collapse and block airflow, briefly waking you.
Nearly 1 billion people worldwide are affected, and risk climbs with age, weight gain, and certain traits. Snoring is a signal, yet many remain undiagnosed because fatigue, forgetfulness, or mood shifts get blamed on stress or aging.
The impact goes beyond being tired. Fragmented sleep from these breathing pauses erodes the deeper stages that support memory. Research from the University of California, Irvine, links sleep apnea to subtle injury in brain regions needed for recall, planning, and clear thinking, even in people who feel generally fine.
Let's dig into REM. During REM, your brain consolidates memory, processes emotion, and stabilizes mood. It's a smaller share of total sleep, but critical.
REM follows a pattern. About 90 minutes after sleep onset, you enter the first REM period, then cycle every 90 to 120 minutes. Early REM is short. Later bouts lengthen. By morning, REM can run 30 minutes or more, so disruptions late in the night hit memory hard.
REM also brings near-total muscle paralysis. That atonia includes the upper airway, so your throat is more likely to collapse and restrict breathing, even if you've never been flagged for apnea.
If you do have apnea, REM is usually the roughest stretch. Breathing becomes more labored or blocked just when your brain is replaying the day and sorting information. Repeated disruption hurts next-day recall and attention.
Because of that, aging and dementia researchers watch REM closely. Even healthy adults who routinely lose it show weaker attention, poorer memory, and reduced emotional control. Stage-specific injury matters.
Yet most clinics lean on the apnea-hypopnea index, or AHI. It counts breathing events per hour but ignores how deep or long oxygen drops and doesn't track the sleep stage. These hidden drops carry consequences for brain health. You could post a mild AHI, yet take severe oxygen hits in REM.
A neurology journal study from UC Irvine highlights this gap. Researchers followed 37 older adults, average age about 73, all cognitively unimpaired. AHI scores ranged widely, but the best predictor of brain change was how low oxygen dipped during REM.
Lower REM oxygen saturation correlated with greater total white matter hyperintensity volume, bright MRI lesions that mark damage to communication pathways. These lesions are tied to memory loss, executive problems, and higher dementia risk.
Deeper REM oxygen drops also meant more white matter burden in the frontal and parietal lobes, areas you rely on for attention, working memory, planning, and spatial reasoning.
Effects extended further. Higher frontal white matter burden linked REM desaturation to thinning of the entorhinal cortex, an early Alzheimer's site. Participants showing these changes did worse on an overnight memory test.
Study author Bryce Mander said obstructive sleep apnea may drive cognitive decline by degrading brain structures that support memory consolidation during sleep. The takeaway: track oxygen depth in REM, not just event counts.
Long-term data back it up. A 10-year sleep advances study of 18,815 adults over 50 examined how apnea and unstable nighttime oxygen influence dementia risk.
Participants with moderate to severe apnea and lower minimum oxygen saturation accumulated white matter lesions faster, even after adjusting for age, blood pressure, diabetes, and other risks. Nocturnal hypoxemia stood out as an independent driver.
Damage often started before symptoms. Many looked cognitively normal at baseline, yet deterioration progressed quietly when apnea was present. Detecting and treating early matters.
A sex difference emerged. Women with known or suspected apnea showed higher cumulative dementia risk at every age measured. By 80, Women with apnea had roughly a 3.7% greater risk. Men, about 2.1%.
Because apnea is treatable, the authors called it a significant, modifiable pathway to dementia, one that may disproportionately affect women.
Treatment often starts with CPAP, continuous positive airway pressure, which blows air through a mask to keep your airway open. Many get relief, but it wasn't intended as a lifelong fix.
CPAP inventor Dr. Colin Sullivan described it as a bridge while you address contributors like excess weight, structural airway limits, or underdeveloped jaw anatomy. Tolerance issues include claustrophobia, nasal blockage, dry mouth, and mask irritation.
Custom mandibular advancement devices shift your lower jaw forward to keep the tongue and soft tissues from blocking airflow. Dentists trained in dental sleep medicine fit these, usually with a sleep specialist.
Orofacial myofunctional therapy uses exercises to retrain tongue position, improve nasal breathing, and normalize chewing, swallowing, and posture. It's useful for mild to moderate apnea and avoids devices or surgery.
Neuromuscular electrical stimulation devices strengthen tongue and upper airway muscles with brief daily use. For advanced obstruction, surgical options such as maxillomandibular advancement enlarge the airway.
Whatever path you choose, training yourself to breathe through your nose instead of your mouth supports steadier breathing and better oxygen delivery, an essential strategy in apnea care.
Lifestyle steps reinforce treatment. Retrain daytime breathing so nasal breathing becomes your default. How you breathe awake carries into sleep.
Reach and maintain a healthy weight. Losing even 10% of excess body weight can improve apnea symptoms by reducing pressure around your airway.
Sleep position matters. Back sleeping lets gravity pull the tongue and soft palate backward. Side or stomach sleeping, or elevating your upper body, reduces obstruction. Positional trainers, specialty pillows, or a tennis ball in your sleepwear can help.
Avoid alcohol and smoking. Alcohol relaxes airway muscles. Smoking inflames and narrows your airway. Steering clear improves oxygen saturation and eases strain on your heart and lungs.
Review medications. Sedatives and benzodiazepines lower airway tone and blunt your brain's response to low oxygen, leading to longer episodes. If you rely on them, talk with your physician about non-sedative options such as magnesium, L-theanine, or sleep-focused cognitive behavioral therapy.
These lifestyle measures are foundational. They reduce apnea severity, protect REM, and help lower cognitive risk.
Here's your challenge. This week, track 2 things: how you breathe while awake and the position you fall asleep in. If you catch mouth breathing, switch to nasal. At night, set up to stay off your back. Log it in a notebook or notes app so you see patterns.
And if you suspect apnea, snoring, waking unrefreshed, or witnessed pauses, push for an evaluation that measures oxygen in REM, not just an AHI score. Early action helps preserve memory. Thank you for watching Dr. Mercola's Cellular Wisdom. We'll see you on the next episode.
Thanks for watching. Subscribe now and click the notification bell so you never miss an update. See you in the next video.